Thanks, Karen. I hope I get through this talk. My wife's going to go into labor at any minute. So if she does, you'll have to forgive me for not finishing. But hopefully not yet. I'm not ready anyway. So what I'm going to talk to you about is novel imaging strategies in inflammatory and degenerative disorders, and really focusing on multiple sclerosis as a model. So my objectives will be to review the limitations of current imaging techniques in the assessment of multiple sclerosis and other white matter disorders, and to present and discuss newer quantitative, functionally relevant imaging methods, including diffusion tensor imaging with fiber tracking and tract profiling that address some of these limitations. And I'll go over all of these terms and what I'm referring to, but the key is to use quantitative methods that we can use to have a reliable measure of how patients are doing and in clinical trials, and also measures of MRI that are relevant to specific kinds of function, which is not currently how MRI is done, and I'll go into that. So why do we image patients? Well, one reason, of course, is for diagnosis, and by far the majority of MRI scans is done for that reason. In the case of multiple sclerosis, we're already pretty good at doing that. In most cases, we can make the diagnosis, and MRI is a major way of making the diagnosis in multiple sclerosis. Of course, we're not perfect, and we're always looking for better methods. Why else might we image? Well, we might be interested in looking at the spectrum of disease within a population, and there are a number of reasons we might want to do that, but one reason is so that we have a really good sense of what one disease looks like as opposed to another disease, so that we can make diagnoses, separate diseases, certain individual diseases, from other ones that might look like that. We may want to follow a patient's disease, so looking for signatures of healing or deterioration. We'd like to know, is the patient responding to therapy? We could do that by examining the patient, talking to the patient, of course, and we need to continue doing that, but imaging might give us a different insight into whether therapy is working, and also to evaluate new therapies. So to talk about diagnosis just briefly, and in MS we're pretty good at this already, and as I mentioned, MRI is a major part of the criteria for making the diagnosis of multiple sclerosis according to the revised criteria from 2001 and subsequently revised since then. And so those criteria have been applied in MS to patients who have clinically isolated syndromes, so something that might be MS. And when you apply those criteria, you find sensitivities and accuracies in the order of the 80s, which is pretty good as far as these things go. And this has been shown in multiple studies. So why else might we image? Well, we want to follow disease over time. We would do this with quantitative imaging, as I mentioned, which is and ideally we'd be able to use measures that are sensitive to many different aspects of disease at once. We'd like to get a measure that has a good correlation with disability, both in the short term, so if somebody has an attack, we'd like to be able to image the attack and the recovery from the attack, but also over the long term, if there's any degeneration going on, we'd like to image that as well. And finally, to image individual functional systems, and by functional system, I mean the part of the nervous system that controls a specific function. So for example, the part that controls vision, the part that controls motor activity, sensation, walking, etc. These are complicated systems, but after 100 years or more of anatomical work, we have some idea where they are in the brain. So what is the problem? Well, so far, the MRI methods that we've used to image MS are not that well correlated with disability. And here's an example of that. This just is a list of many different studies that were done looking at just one aspect of correlation. So one aspect of MRI is on the so-called T2 weighted scans. How many lesions do you see? And correlate that with the EDSS scale of disability. And so you see very many different studies that are addressing this question, all different kinds of correlational values. If you plot these, you find that in the studies that have the largest number of patients, the correlations are on the order of 0.1 or 0.2, where maximum is 1, minimum 0. And so you see that the correlation is really pretty poor, even though this is primarily the way we make the diagnosis of MS is by using these T2 lesions and where they are. Some have argued that we're not going to get much better correlations just by the nature of the imaging and the nature of the disability scales, but overall we'd like to do a little bit better than 0.1 or 0.2. So I've told you about correlation. Now I'll tell you about imaging functional systems, and I think this might give you an idea of the current status, the state of the art, and where we are, how we need to do better. Specific imaging of functional systems is not routinely used in clinical practice. And so here's an example. This is an MRI, a single slice from a patient I admitted early one morning who had the sudden onset of weakness on one side of his body. And when we saw him in the emergency room, it seemed to us, based on the interview, the exam, his risk factors, that this patient was having a stroke that was causing weakness on the right side of his body. And so we shipped this patient off to the MRI scanner, and lo and behold, when they did the diffusion-weighted image, there was a bright spot right here. And bright spots on diffusion-weighted images often correspond to acute strokes. And so what we had was a clinical picture where a patient had acute onset of right-sided weakness, and here on the left side of the patient's brain, where these images are reversed from what you want them to be, there was an abnormality. Now, from the imaging alone, we see that there's an abnormality there. We know from our knowledge of brain anatomy that this is in the region of the motor pathway in the brain, but we don't know that for sure. And so by putting all the information together, that is how the patient presented, what you see in the MRI scan, we can make inferences about which functional system was involved in this patient's disease. That is the motor tract, because of his weakness. But we'd really like to be able to do that directly. That is, we'd like to be able to image the motor system specifically from the get-go and not have to use all sorts of additional information to make our decisions. And we can do that now with a technique called diffusion tensor imaging, and this is what you get after you do all the analysis. And what this shows you is superimposed on a three-dimensional MRI scan of the brain. These red tracks are basically showing you the course of the two motor systems in the brain, one on each side of the brain. And so we know exactly where they are when we do this kind of imaging, and we can say, well, let's throw away most of the 4 million little pixels that we get when we do this image and focus only on the pixels that are contained within this motor tract and analyze the MRI aspects of that and ask whether that tells us more about why people are weak or what are the imaging correlates of weakness. So that being said, I'm going to talk to you about our arsenal of quantitative imaging methods. I'll go over this fairly briefly. I'll talk primarily about diffusion tensor imaging, which is what allows us to get these nice pictures of where the functional systems are. I'll briefly mention other methods we use that are quantitative versions of standard MRI images that you might get when you go into a scanner, and briefly magnetization transfer imaging, which is sensitive to myelin and, of course, of paramount importance when you image multiple sclerosis and related disorders, demyelinating disorders. I'll then tell you how we do fiber tracking, how we reconstruct these pathways. I'll introduce a concept called tract profiles, which allow us to see what's going on where along these functional systems. I'll give you a few examples, and I'll talk a little bit at the end about how this might be correlated with disability, with the patient's functional status. So the principles here, sort of schematically in cartoons, is that when we do MRI imaging, what we're really looking at is water in the brain. And water moves around randomly, and if it's free to move around randomly, it can go in any direction it wants, and we call that situation isotropic diffusion of water. But if water is trapped because of structures around the water, for example, bundles of nerves that are all running together like this, then water is more likely to diffuse in one direction as opposed to in another direction, and we have a situation called anisotropic diffusion. And we can exploit this to make maps of where in the brain water is able to diffuse freely and where in the brain it's able to diffuse primarily in one direction over another, and we can use that information to make a map of where these tracts are in the brain. And so this is a movie showing you the diffusion, the raw diffusion-weighted images, and each frame of this movie is a different image sensitive to motion of water in a different direction. And so you can see different parts of the brain get lighter and darker depending on which direction of water we are asking about. And by integrating all this information together. So, for example, here, you might have fibers or axons running in this direction, and this allows us to sort that out. So you can integrate all this information together and get a raw map of the amount of diffusion of water at any particular spot in the brain. And you can see here in the cerebrospinal fluid containing ventricles of the brain, it's very bright because water is able to diffuse over long distances, and in the brain itself, it's darker because water doesn't diffuse quite as far. You can ask about the amount of water that's diffusing parallel to the axons, to the nerve cells, and here you could see that. And if you ask about where water is diffusing perpendicular to the direction of the nerve cells, we get a different image. And you can see, for example, in regions like the corpus callosum over here, or internal capsule, where all the axons, the nerve cells, are oriented together, we get high amount of parallel diffusion. It's brighter, whereas we get low amount of perpendicular diffusion. And so those are areas where we get cells that are running together. We make that inference. This functional anisotropy map kind of distills that into a picture where you see very bright areas where all the nerve cells are running together. Those are the big white matter tracts of the brain. We can even color that in and add information about what direction the water is moving, or what direction the nerve cells are going. So in this case, blue would be into and out of this picture, red across, and green front to back, and various combinations of that color tell you something about oblique directions. These are the other quantitative maps we use. I won't go into how we get them, but we have measures of T1 and T2, which are fundamental magnetic properties of brain tissue that we can measure, and magnetization transfer ratio, which, as I mentioned, is sensitive to myelin, primarily. So I told you about how we get these images. Now I'll tell you about how we reconstruct these functional systems. We do that through fiber tracking. This is based on the diffusion images. And what we do is, for each pixel of the millions that we are getting, we ask about the primary direction that nerve fibers are going. We start in each pixel, we look at where that pixel is pointing, we find another pixel, and we just continue doing this until we get to a point where we have to stop. And we stop because we are getting to a situation where the bundle of fibers we're looking at is turning too fast. It wouldn't make sense anatomically, or because we get to a place where where our imaging isn't very good. And so we just do this over and over again. We get a fiber, and we do this for every pixel in the brain, and that gives us a sense of what pixels are connected to what. And the way we pull out of this huge amount of fibers the functional system is we use anatomical information. So, for example, here we know that if we look at the cerebral cortex, this is the motor part of the cerebral cortex, and this is the midbrain, we know that the corticospinal tract, the major motor tract in the brain, connects the brain, the cortex of the brain, from here to here. So we only ask about the fibers we've reconstructed that connect these two positions, and that will give us the top portion of the corticospinal tract. We can play the same game in the brainstem, connecting the midbrain here to the medulla, and we can get the brainstem portion. And we can also do the same thing for the whole brain. So this is how we use the diffusion tensor imaging to reconstruct these tracts. And again, I'll show you this picture, which is a map of where the tracts are over the whole brain. We can play the same game in the cord and begin to address questions of relevance in transverse myelitis. The cord is more straightforwardly ordered than the brain is, but of course it's a lot smaller and harder to image. But we can use these techniques to reliably separate out the dorsal columns, which primarily carry sensory information, from the lateral columns, which primarily carry motor information, and play the same games with this that we are in the brain, and ask similar questions. I'm going to talk about the brain for the rest of the talk. So the next thing is told you about how we get these tracts. Now I'll introduce this concept of tract profiles, which allow us to ask specifically, if there is an abnormality, where along the tract is that abnormality. And so here we have one of those tracts superimposed on a sagittal slice of the brain. And just schematically, if we turn the brain on its side, we can divide up that the length of the brain into segments that we can identify in every individual. And as a function of the distance along this axis, along this plane, we can then co-register one individual to the next and ask about the behavior of the MRI along at each of these positions along the brain. So we have a bunch of different areas in the brain, and here's what you get if you look at a bunch of healthy controls. You can see that for each of these MRI parameters, the shape of the variation in the MR signal as a function of where you are varies, and it varies with some real sort of reproducible variation. Okay, so that's how we do these tract profiles. We're going to use these tract profiles as a way of showing us a specific functional system in the brain. And now I'll show you some examples. I'll show you two individuals with multiple sclerosis, how we might connect up, their lesions with the functional system, the motor system that we're looking at. I'll show you then average tract profiles, so averaging across many patients with multiple sclerosis, which will give us a sense of the spectrum of disease within the motor system. So this is the first patient. This is a 32-year-old man who had the acute onset of motor weakness also on the right side, just like that stroke patient I showed you before. But this patient had multiple sclerosis, and at this site in the subcortical white matter, the patient had a lesion that was enhancing with contrast. This is a so-called flare scan of that same area, and you can see that there's a lesion right here. The patient had right-sided weakness. Well, we can do fiber tracking and look for the pathway of the motor tract in this patient, and you can see that here is that lesion, and it's interacting directly with the motor tract in this patient. So, of course, you might say, well, that's not very surprising. This patient was weak on that side, so we would expect to see that the lesion is interacting with the motor fibers, but here we're imaging it directly. We didn't need to use that information to know that this patient's corticospinal tract or motor tract was involved in this acute attack of his multiple sclerosis. And you can see that there's this pathway appears to be split by the lesion, whereas the one on the other side is fairly intact. So, and when we do these fiber tract profiles on this patient compared to an average of 56 controls, you can see that in this region, which is where the lesion was, this patient's mean diffusivity was dramatically increased, which is what we see in multiple sclerosis. So we can now say not only was the corticospinal tract involved in this patient's presentation, but where it was involved and how much it was involved quantitatively, and presumably follow that over time. This is a second patient. Again, I'm showing you mean diffusivity, so the amount of water diffusion over time, or per time, and that's related to, that's abnormal in multiple sclerosis. This again is average from controls as a function of position in the brain. This patient was imaged 3 different times 6 months apart. This was time 0, this was at 6 months, and this was at 12 months. And you can see there's some variability within individuals that we get when we don't have many individuals to average over. But this spot in the pons was consistently elevated on all 3 scans, so we decided to look back at the original images in that area and ask if there was something abnormal. So we looked at the pons, and what we found was a lesion right here. Now, you might look at this lesion and you wouldn't know a priori whether or not the motor tract was involved, but we're finding based on this tract profiling that it is involved. Well, that's interesting because this patient had no motor symptoms. But we know consistently that the motor tract is abnormal in this area. So you might say that this patient is at risk, that this patient's motor tract is at risk, that there's that another hit, for example, along the motor tract might cause severe disability in this patient, and with that information, you might then go back and change the way you're treating the patient to try to protect that tract more intensively than you would otherwise do if there was no abnormality in the tract, given the risks of therapy. So we can use this information not only to see where a lesion has already happened, but also to assess whether a tract is at risk or not, and that can be very helpful for clinical practice. So now I'll show you some average pictures, and the reason this is interesting is because, as everybody in this room knows, MS and related disorders are very heterogeneous. No two patients are affected exactly alike. And so you might say, well, if we averaged across all of the patients with the disorder, we might see nothing because everybody's affected somewhat different. But in fact, we don't see nothing. We see that consistently there are abnormalities across the entire spectrum of the population of individuals with multiple sclerosis with various degrees of disability. And so, for example, in this parameter, MRI parameter, which is sensitive to myelin, primarily on average, 39 cases of multiple sclerosis, the overall tract profile was shifted down compared to the control patients. We expect this parameter, MTR, to go down when there's loss of myelin. But again, these were patients, some of whom had weakness, some of whom did not have weakness, and averaged across all of them, and there's a reliable effect here. Mean diffusivity, we again average across our full population, but instead of finding an abnormality across the entire length of the tract, we find more focal abnormalities in this region, which corresponds to the region around the CSF spaces, around the ventricles, which is where we know a lot of multiple sclerosis lesions are. And so if you average across that population, you see that the abnormality in diffusivity is primarily focused in this region. So again, by looking at a lot of different parameters, MRI parameters, such as the magnetization transfer effect and mean diffusivity, we can begin to construct a picture, an overall picture of where the MRI is abnormal, who it's abnormal in, and what these different MRI parameters are sensitive to as far as hopefully as far as the underlying pathology of the disease. So I've showed you some examples, and the last thing I'm going to do is very briefly show you how some initial hints at how this all might be correlated with the patient's functional status, how well they're doing, or unfortunately how poorly they might be doing. And so here, for example, are two profiles of the T1 parameter of tissue in 26 tracts from patients who were weak and 17 from patients who were not significantly weak. That is, you couldn't distinguish their strength from the spectrum of healthy people of matched age and gender. And there's a significant difference between these two groups. The patients who were weaker had a higher value of this T1 parameter across virtually the entire length of the tract. We know that this parameter T1 goes up in cases of multiple sclerosis, so this is what we would expect. We know that higher values of T1 within lesions of MS are correlated with disability, and so we see this effect. And I should just digress here in case I've confused anybody by this higher and lower T1, that the absolute value of T1, which is what we're measuring here, is flipped from what you see in these MRI images. So when we talk about T1 holes and things look darker on those images, it actually means T1 is going up. So sorry for that digression. It's just the way it is. And finally, the last thing I wanted to show was this picture where we take a look over the entire motor tract and we get a measure of the total abnormality of that tract. And we again compare these two groups, weak and less weak. And we see that for every single parameter that we've measured, the total abnormality of the tract was greater in the weaker group and less in the less weak group, and that was significant as well. So what this is saying is that when we look at specific functional systems, we can get measures that are directly related, although not as strongly as we would like, but related to abnormalities in the motor system in individual patients. So with that, I think I'd like to close and just thank primarily all the volunteers who have participated in this ongoing study, which is a large study, and to thank a number of people who helped do the work, in particular Peter Calabresi, who's sort of the boss of the whole project, and Eliza Gordon-Lipkin, who has coordinated this study very expertly, Seth Smith, who's helped me a great deal with the MRI aspects, and Peter Van Zyl as well, and Kathy Zakowski has been doing the functional measures, who you've heard from, I think, yesterday. So with that, I'll close, and if there are any questions, I'm happy to take them. I guess my wife's not in labor yet.